Hello everyone, hope you're all safe. This is Dr. Nerd. In this video, we're going to go over the first pathology lecture in the cardiovascular system about arteriosclerosis. So, what is arteriosclerosis? Arteriosclerosis it means the hardening of the arteries, and this term is not the most accurate one because yes, it tells you that the artery is hard, but it doesn't exactly tell you how it's becoming hard. Um, so how exactly is by thickening the arterial wall and loss of elasticity. So here you can imagine that elastin found in the artery is being degraded. So arteriosclerosis is a chronic inflammatory process, a long-term process. It could take 10, 15, 20, or even more years, years or more. But there are types of it, like four types. Like there are the fibromuscular intimal hyperplasia, arteriolosclerosis, sorry, Monkenberg medial sclerosis, and atherosclerosis. For fibromuscular intimal hyperplasia, this is really like the most least common to be discussed in your exams. But the only thing you have to know about is that it is caused by repeated injury. So, like any form of injury. Most commonly, they will tell you one of the causes of it is like patients who receive organs and face organ rejection, are commonly to have these kind of problems like fibromuscular intimal hyperplasia. But really, you don't have to know about it like that much. Arteriolosclerosis and Monkenberg medial sclerosis, I'm gonna be talking about towards the end of this video, hopefully. And lastly, atherosclerosis. Atherosclerosis is really the most important form of arteriosclerosis, and this is the scope of this video. So if there are two things you have to know about arteriosclerosis would be the risk factors as well as the pathogenesis. So what about the risk factors? So risk factors, as you know, um, there are two types of risk factors, the modifiable and non-modifiable risk factors. Modifiable those that you can control, you can change, and the non-modifiable that you cannot change. And those are gender, males are more prone than females, age, so males who are older than 45 and older are more prone to atherosclerosis, and 55 and older are prone to atherosclerosis as well. Now, for the family history, I want to make sure that you don't mix these numbers up. So I'm gonna give you an example, two examples that hopefully gonna clarify the concept. So you have one patient. His name is Mike. He is 42 years old, and his father had atherosclerosis at the age of 60. Now, I'm gonna ask you, how many risk factors does Mike have? He has really none, because family history, his father, first of all, his age is less than 45, he's 40, so he's not at risk of developing atherosclerosis, but his father had atherosclerosis, so isn't that family history? It's not, because it says for family members, the male family member who would give you the family history risk factor should be 55 years old and below. So 55 years old and below for males members, family members, and for females 65 and below. And we're talking about first degree family members. Those are like mothers, fathers, sisters, and brothers. So make sure you don't mix these two up. And then genetics. Then the modifiable risk factor, hypertension, diabetes, smoking, hyperlipidemia, obesity, more specifically central obesity, that's metabolic syndrome, and so hyperlipidemia, as I said, inflammatory diseases like systemic lupus erythematosus and other systemic diseases, physical inactivity, stress, and others. I just want to mention that this risk factor could be for any other heart disease, like coronary syndrome, for aneurysm, for atherosclerosis, and many other heart diseases. So really, there are. Now for the pathogenesis. Pathogenesis, as I told you, is very important. It's very high yield, and I underlined it there. There are many hypotheses has been many hypotheses talking about pathogenesis of atherosclerosis. The most important one, and the one that's most commonly studied, is a response to injury hypothesis. From the name, it's a response to injury. So it's like there's an injury, then inflammation, and so that develops this phenomenon or disease. And this diagram that summarizes it, but let's go over it step by step. So first of all, you have this vessel. It's really a normal vessel. It has layers. It has endothelium. It has intimal layer. It has media, which is the muscular layer, and then the adventitia. I forgot to tell you that atherosclerosis really is in intimal region. So in the intima, where the whole thing is really going on. But the key player in the atherosclerosis is really the endothelium, because it starts with an injury to the endothelium, right? So what kind of injury that does happen to these poor endothelium cells, epithelial cells? Any one of the risk factors. So like chemical irritants like smoking, hypertension, mechanical, hyperlipidemia, homocysteine. I forgot to tell you that hyperhomocystinemia is really a risk factor. Hemodynamic risk factor, like any type of hemodynamics, like even at the bifurcations and so on of the arteries. It's really a common place for atherosclerosis to develop. Toxins like certain bacteria, viruses, and immune reactions for like systemic diseases. And then there is an injury to this poor endothelial, these poor endothelial cells. Once this endothelium get damaged, monocyte macrophages and so will start diapedesis and will enter, as well as for these lipid cells, lipid particles, LDLs, specifically LDLs, because the most dangerous one. So endothelial dysfunction, leukocyte adhesion, and so on. Now, macrophages start engulfing these fat lipids, is shown here. So they've engulfed it. Start the oxidation of these lipid molecules and oxidation. So oxidation happens. Some free radicals will be emitted, and which will worsen the case. Something very interesting happens in this pathogenesis is that small muscle cells have been recruited in this. They participate in this disease, and these small muscle cells are coming from the medial layer, from the artery itself, and from the stem cell to the bloodstream into the site of injury. Once these smooth muscle cells have been recruited, they change. They are no longer contracted. They're no longer contractible. They do not contract, and they start engulfing fat as well. So they're very weird. Lymphocytes, most commonly T lymphocytes, get involved in the process as well. and we see these fatty streaks. They say that everyone beyond the age of 10 they have fatty streaks. It's really not that dangerous because it's really not that protruded into the lumen, does not obstruct the flow, um, and really is not that serious. But if it persists, atheroma starts to appear. Now, when it's only purely fat, it's fat atheroma or fatty atheroma. But once the collagen appears, it is fibroatheroma. Okay, so this collagen starts to form. Extracellular matrix starts to deposit. Actually, these collagen fibers being recruited also by the smooth muscle cells, so the smooth muscle cells also recruit collagen. New vascularization occur, but they're very weak, as you know, vessels and so. So, in the middle here, there is like necrosis, lipid debris, and so collagen at the outside. The thing is really protruding inside the lumen, obstructing the flow. It's really a mess. And at the end, something like this will form. So there's this center, the necrotic center with the fats and the macrophages. I forgot to mention one thing, that once macrophages engulf fats, they form this form of macrophages. It's called the foam cells. So they are foam cells after they involve they foam cells. New vascularization, as I mentioned, smooth muscle cells, and then the center. I want to talk about something very important here, which is stable versus unstable atheroma. So between these two, which one you would think is more stable? The answer is this one, because first of all, the lipid core is very small. It's a small one compared to this one. It's very huge. Number two, the fibrous cap. This part here is the fibrous cap, and the fibrous cap is very thick, meaning it is less prone to explode. Here is very thin, and with like increasing pressure or so, it could fissure here or something, and all this content it's going to be a mess. Also, the macrophages or the inflammatory cells. Here they are more in number than these. It's like more inflammation, more stability, literally. Now to the gross picture, the morphology. Now here it's shown like a little bit of fatty streaks. One thing about the atherosclerosis, it really developed at the ostia, at the opening of the artery. Now in this image here, you can see a little bit of atheroma. It's really unstable atheroma. And if you look here, you can see this brownish color. And this is actually a superimposed thrombus. So thrombus developed over the atheroma because it's one of the things that could happen. Now under the microscope, this is exactly what fatty streaks look like. So washed out fat, emptiness, now here there's a cross section of a coronary artery with atherosclerosis. You can see here the core. You can see here the fibrous cap. This side is normal, but this side is not. Is kind of abnormal. And if I ask you if this thrombus is stable or unstable, the answer is stable because the fibrous cap is really thick, the core is not that big, and it looks quite stable. And this blue color is the collagen stain. The collagen stain that stains collagen blue. You can see the extent is so much collagen here. Now in this picture exactly, you can see two different things that may happen in atheroma. So here you can see a little bit of fissuring here. So it starts to open up a little bit, the thrombus. But here, it's fissured and blood leaked, and there is superimposed the thrombus. And the whole circumference of the artery is thickened and is quite abnormal. So now, what could happen to this atheroma? It could cause weakening because we are talking about something that's growing in the intimal layer of the artery itself. And it really could weaken the wall and could lead to aneurysm and rupture of the vessel. Thrombus and embolism, as I mentioned, the thrombus and the embolism, it cut off and move to the narrower artery and block it. Progressive with the growth and narrowing of severe narrowing of the vessel. Now, most common and least common affected vessels. Lower abdominal aorta is really the most commonly affected. Coronary artery, popliteal, and the least common is the circle of Willis. For the upper limb arteries, they're really not that commonly involved in the thing. But why these are important is because of the complications that atherosclerosis may result with. So for the coronary artery, as I told you here, coronary artery could get involved in atherosclerosis. It's really likely to get involved in atheroma. So this could lead to MI, ischemic heart diseases, cardiac arrest, and so forth. In the carotids, it could lead to stroke or ischemic encephalopathy. In the popliteal artery, it may lead to gangrene, peripheral vascular disease, and so. Ischemic bowel diseases because of an embolism or an atheroma at the ostia, really. Or aneurysms, as I told you, because of weakening of the arteriole. Now we'll talk about other types, as I promised. Arteriolosclerosis, as the name implies, arteriolosclerosis, so small arteries and arterioles. And really the cause of it is hypertension and diabetes. And there are two types, the hyaline arteriolosclerosis and hyperplastic arteriolosclerosis. Now the hyaline, you can see here, it's like this pinkish color, excessively pinkish color. And the reason why it's pinkish is because of this proteinase, proteinous matrix that's happen here. Now for hyperplastic arteriolosclerosis, you can really see that it is quite organized in a way. And the problem in these, they could lead to ischemia after the point where they happen. Now, Mockenberg medial sclerosis, it is really the main cause of it is aging. So with age, the arterial wall gets less elastic, and yeah, so older than 50 years old are more prone to have this thing. Mockenberg medial sclerosis, and it's not really that significant. It's not atherotic. It does not cause any problem. Now, this brings us to the end of this video. These are the resources. Most of the things that I talked about are from Robbins. Most of the pictures that I talked about, that I used in this video, are from Robbins. So take a look at the book. Read it. It really explains it in a very good way. Thank you.